Hi guys, let's talk about hypertension. This is going to be an overview lecture of the hypertension disease. If you're looking for medications, it's going to be in a different video. All right, well, what is our good old hypertension? And it is a very common disease that a lot of patients experience in the hospital. Pretty much, this is when the force against the blood vessel walls, it's very increased. So that's what blood pressure is. That's that measurement of volume or the flow that is basically being pushed or against the walls of the blood vessels. Now, you know, typically we kind of know blood pressure as the 120 over 80, but guidelines have changed, and I will kind of talk to you here shortly about what is sort of normal, elevated, and crisis. Let's talk about what actually affects blood pressure. There are a few things that really make your blood pressure or can make your blood pressure high or low. So the first thing is your heart of how fast is pumping. So we call that heart rate, the frequency of your heart pumping. We also look at the force of how forceful is squeezing, that contractility of the heart. So if the let's say the muscle is weak and it's not pumping with so much force, then it's going to affect the blood pressure. All of this is actually affected by your nervous system, and specifically your sympathetic nervous system, your fight or flight. So let's say you are under a lot of stress, or you're frightened, or you're going through this fight or flight mode. Yeah, your blood pressure is expected to rise because of those components. Another category of things that affect the blood pressure is the resistance of your heart pumping against these vessels. And it's affected by how narrow or how dilated your vessels are. So if my heart is trying to pump against a vessel that is narrow, built up with, let's say, plaque, or it's sort of constricted, then my blood pressure will increase because I'm going against force. I'm going against something that is literally squeezed or narrow. Versus if it's dilated, it's open up, all the pipes are wide open, my blood pressure will be low because the force that I am pushing against is less. Another thing to look at, another factor is fluid volume. How much volume does is the heart pumping out? And fluid volume is kind of the same. I'm going to use those words interchangeably. Can basically be affected by many things. It could be affected by sort of dehydration. It could be affected by medications. It could be affected by alcohol, such as the antidiuretic hormone. Um, when our bodies detect that we are dehydrated, the antidiuretic hormone sort of kind of kicks in or not kick in, and then it doesn't let us excrete or retain fluid, and therefore our kidneys kind of monitor how much fluid we're being peed out or not peed out. And also this aldosterone that we're going to learn that also retains water and sodium, as well as constrict vessels and whatnot. So, kind of three major factors we're looking at are how fast is it pumping, and the strength that is pumping, your sympathetic nervous system, as well as your vessels, how constricted or how dilated, and then we're dealing with volume here. So that's just a little bit of pathos so you understand that blood pressure is affected by many things. And when we look at medications in a different lecture, you're going to hear me referring to some of the meds. Oh, this controls heart rate, or oh, this controls the volume fluid that is being um, expelled out through the kidneys. So let's look at the classification of blood pressure. So blood pressure in the new guidelines of the American Heart Association's change. And now normal blood pressure is said to be less than 120 and less than 180, excuse me, less than 80 dystolic. So your good old 120 over 80 is no longer sort of accurate. It's said to be elevated if you actually have a blood pressure of 180, 120 or over 80, so to speak. And then you go into stage one, stage two, and then your hypertensive crisis. So when we look at patients in the hospital, you also kind of want to know what is their normal blood pressure ranging? Are they normally in the one teens systolic, or are they normally in the 130s? And now it's, let's say, 160 systolic. So consider the client individually. It's the good old kind of saying, like, we nurse the patient, not the monitor. But we also kind of know that a lot of medications can affect your blood pressure, and the stress of the body being at the hospital itself or diseases can also affect the blood pressure. So who's really at risk here? Well, we got to consider, like a little drink of water here. We got to consider that, some of the factors that make someone at risk for hypertension are non-modifiable. You're born with them. You're born with your gender, you're born maybe with your race, you're born with, yeah, family history, as well as you age and you cannot control how fast or how slow we age. I wish we can, actually. So some of the things we can modify, some of the things we can't. um, People that are at risk are men over the age of 55 and women over the age of 65. If you smoke, if you have other comorbidities such as diabetes is a huge one. Also, high cholesterol levels, like elevated serum lipids from triglycerides to bad cholesterol, etc. And then if you drink, if you are overweight, if you are sedentary at your house and really don't do a lot of exercise. Another thing that we consider is the diet. If your diet is high on fats and as well as sodium. And then, people don't really relate stress, but I've been kind of saying stress is almost like a silent killer, and it is a silent factor that almost damages the body inside because it increases cortisol, which is kind of sugar, and then it just messes up with a lot of things. This part over here where I listed socioeconomic status. Well, that's also to consider because you got to look at culture, you got to look at socioeconomics when we're dealing or when we're considering someone. Are they at high risk? If they cannot afford good nutrition or healthy nutrition, hey, they're not going to eat very well. Or if, let's say, we're dealing with a culture that is all surrounded with fried food or bready, sugary, fatty items, fatty like items of food, then it's going to be hard for them to modify their lifestyle. And so we do consider socioeconomics, okay? What do these clients look like? Well, honestly, these clients look like normal people. Most of them, you're not really going to see a lot of symptoms unless, and I'll say that again, unless it actually complicates to something else. So it is why they call it the silent killer, because a lot of individuals, a lot of clients suffer from hypertension and they don't even know it. Okay. And I include myself on that. Maybe on a very stressful day, you might take my blood pressure as, maybe my nurse, and you might say that my blood pressure is, I don't know, 128, 130 systolic. And you're like, oh, Miss B has hypertension. Well, yeah, due to my stress and due to maybe a lot of things that I'm going through. So, but I don't look like a hypertensive person? So yeah, most of the times it's a silent killer unless it develops to a different disease or other organs are affected, then you possibly could have this fatigue, dizziness, palpitation, short of breath, maybe some chest pain, and then headaches. And I put a question mark on headaches because you will hear a lot of clients say, I know my blood pressure is elevated because I have a headache. It's just the force of the blood vessels, just kind of that pressure of the hypertension. And in some of the clients, it develops like a headache. Now, also the book talks about something along the lines of white coat hypertension, and basically what that is that patients, whenever they go to the doctor's office or they see someone medical related, they sort of get nervous and they get blood pressures, elevated readings. But it's just due to the white coat or the medical being in a clinic, in a hospital. And that is why we don't diagnose hypertension on just one blood pressure reading. And we'll talk about how we diagnose it here shortly. Hmm. So, what are the complications of hypertension? Well, it actually creates a lot of problems related to the vascular system. So, and also the heart. So we can have maybe kidney disease, like the vascular, since the kidneys are very vascular, it'll damage the kidneys vessels. You can also have peripheral vascular disease, maybe strokes. You could have coronary artery disease, hypertension, also can cause like a heart attack, heart failure. So some of these are the complications. And as a nurse, you might want to educate your client on like, hey, we got to control your blood pressure because this could lead to other very serious diseases. And then how do we recognize that perhaps someone is developing heart failure or peripheral vascular disease? Let's talk about how we diagnose it. Well, I mentioned earlier, I said we don't diagnose it on just one reading, and that's very true. Just because you will go one time to your doctor's office and your blood pressure is high, he will not say, just based on one reading of blood pressure, will not say, oh, here is this blood pressure medication I'm prescribing to you, go home and take it. Typically, what we like is to monitor the client sort of with a log of blood pressures throughout their day. But we diagnose it on, yes, blood pressure readings, but we need to see it for a few days, a trend, or perhaps look at other things that could lead us to other possibly experiencing hypertension. Some of these things that we look at or the physician will order is, let's say, well, let's look at their glucose level. Could they be having diabetes as well? Let's look at their lipid panel. Could they be having high triglycerides and high cholesterol? Could their kidneys be affected already? How is their creatinine level, kidney function? Now, if some of these are in place or some of these are positive, and you have elevated blood pressure, then yeah, we probably have issues already, like secondary issues, okay? Um, or perhaps, maybe the physician might say, listen, go home, monitor your blood pressure for 2 weeks. I want you to take it in the morning, midday, and then evening, and come back. Let me see you in about 2 weeks and we'll review that log. Um, And then they'll start them on a little medication, a little bit of, let's say, lisinopril, which is an ACE inhibitor, and then see how they act to the therapy. Okay. Oh, I did not mention earlier, and let me actually say this: pain increases blood pressure because of the stimuli in the sympathetic nervous system. And so, for example, you might have patients that experience chronic pain that also develop hypertension. You treat their pain, or you, let's say it's a knee. I say this example because of my client population. They fix the knee, they have knee problems from arthritis, they fix the knee, and they no longer need hypertensive medications. So I forgot to mention that earlier. So now what do we do once we realize, okay, well, they are hypertensive. We're gonna treat them. What are some of the things that we can do? Well, honestly, just like diabetes, the therapy for hypertensive is not just medications. Yes, medications are part of the treatment, but it's not all. You really have to do lifestyle modifications, from controlling your cholesterol, your sugar levels, if they're applicable, if you're developing diabetes, losing weight, eating better, exercising, stop smoking, stop drinking alcohol, reduce your stress, maybe eliminate that pain, um, and and in combination with, yes, a drug therapy. So we say that if you lose 1 kilogram, which is 2.2 pounds, you can lower your systolic blood pressure by 1 mmHg. Also, they recommend the client to do moderate intensive aerobic activities, like getting your heart pumping fast, not just slow walking, but moderate intensity aerobic activities for at least 30 minutes for most of the days of the week, 5 or more. And then this DASH diet that includes, I'll show you here in a minute, in the pyramid, includes, you know, um, substituting more veggies and fruits, like large portions per day, and then switching your grains to wheat grains and more healthy grains instead of the white breads and the white potatoes and whatnot. And then doing like low fat dairy, eating more fish, more nuts, because they contain that good fats, like avocados and nuts and whatnot, and then limiting at the top of your pyramid those sweets, or those bad sort of fats, like saturated fats and whatnot. We also educate them about how to read labels as well, just like the diabetic patients. Sodium and salt levels are going to be very important because salt attracts water. Okay. And so water follows salt. And so if they're eating lots of salt, then your blood pressure will increase, because the body's going to say, whoa, I got to dilute all this salt. I got to keep more volume, more fluid within my vessel. Um, and so reading the labels of, how much cholesterol, how much saturated fats, and how much sodium intake I'm taking, and keeping, staying away from all these frozen meals, um, canned meals or canned foods. They all contain a lot of sodium, because that's how they preserve them and make them last longer. Okay. Um, let's see, what else I want to tell you. So how to read those food labels, and DASH diet is very important. So a lot of education with these clients, guys, not only from the medication standpoint, but how do we modify these modifiable risk factors, and knowing also that it's not just the pharmacological therapy, but they need to lose weight. They need to eat better. They need to reduce their sodium intake, their sweets. They need to not develop other comorbidities like diabetes, etc. And that hypertension can lead to other deadly diseases. And who is at higher risk? Okay. I hope this was helpful. This is just an overview on hypertension. I will record another video for medications alone. Here are my references as always, and I will see you in the next video. Bye-bye.